Meet Mr. Tanaka, 54 years old, 10 days into chemotherapy for lymphoma, and this evening he spiked a fever, 38.5. That is the only thing that has changed. His heart rate is 92, his blood pressure is 124/76. He has no cough, no pain, no obvious source. He is sitting up, talking, and by every ordinary measure he looks well, and yet this calm, comfortable patient is one of the most dangerous people on the unit tonight. To understand why and to know exactly what to do, we walk the same 6 steps, 1 patient, 6 decisions. Let's begin. Step 1. Recognize the cues. And this case is a trap, because the most important cue is the one that is easiest to walk right past. Look at everything. The vital signs, the exam, the history, the labs. Most of what you see looks reassuring. A normal heart rate, a normal pressure, no distress. So your instinct might be to relax, resist it. Somewhere in this chart is a single number that changes the meaning of everything else, and a single finding, the fever, that in this particular patient is not minor at all. Slow down, look past what seems normal, and pick out the cues that actually matter here. Open the Vital Signs tab, and here is the first trap of this case. His temperature is 38.5, up, a fever. But now look at everything else. His heart rate is 92, normal. His blood pressure is 124/76, normal. His breathing and his oxygen, unremarkable. If you stopped at this tab, you would see a comfortable man with a mild fever, and you might be tempted to simply watch him overnight. Hold that thought, because one tab over, a single number is about to change what this fever means. Now the Labs tab, and this is where the case turns. Most of this panel is the expected wear of chemotherapy, a low hemoglobin, a low platelet count. But find this line. His absolute neutrophil count is 400. Neutrophils are the white cells that fight bacteria, and 400 is severely low. The chemotherapy has emptied his defenses. That one number reclassifies the fever you just saw. A comfortable man with a mild temperature becomes a neutropenic patient with a fever, and that is an emergency. Here are the cues that count. First, the fever, 38.5, on its own, in most patients, a mild fever. Second, and this is the key, his absolute neutrophil count is 400. Neutrophils are the white cells that fight bacteria, and 400 is severely low. His chemotherapy has wiped them out. Third, he has no localizing source, no cough, no wound, no burning with urination. And fourth, the timeline, 10 days into chemotherapy, right at the nadir, when the counts bottom out. Now hold those together. A fever, in a patient with almost no neutrophils, with no source you can find. That is not 4 separate findings, it is one diagnosis, and it is an emergency. Step 2. Analyze the cues. And here is where clinical judgment separates a safe nurse from a dangerous one, because the same findings mean completely different things in different patients. In a healthy person, a single low-grade fever with no source might reasonably be watched overnight. So take each finding and ask, not is this normal, but is this normal for this patient? He looks well, but a body with no nutrients cannot mount the redness, the pus, the swelling, the high fevers that normally announce an infection. So the absence of those signs is not reassuring, it is the disease hiding. Sort what would be benign in a healthy host from what is an emergency in a neutropenic one. Sort them honestly, and almost everything moves into the emergency column. Yes, a little chemo fatigue is benign. But the single fever? In severe neutropenia, one fever is the emergency, because it may be the only sign the immune system can still produce. No localizing source? Not reassuring, alarming, because he cannot localize it. The infection is there. You just cannot see it yet. And looking well? With normal vitals? That is the most dangerous part. Because a neutropenic patient can look perfectly stable and be in florid sepsis within hours. The lesson is hard, and it is the whole point of this case. In neutropenia, you do not wait for the picture to look bad. The fever alone is the alarm. Step 3. Prioritize. Name the one problem that drives everything. And notice the pull of the reassuring options, the temptation to call this a mild virus, or a harmless chemotherapy side effect, or a bit of dehydration, and to simply watch him overnight. Any of those, if you are wrong, could cost this patient his life before morning. So weigh them against the alternative, that a fever in a severely neutropenic patient is an infection until proven otherwise. Which problem, if you commit to it, forces you to act now? Put that one at the top. The priority is neutropenic fever, and it is a true medical emergency. Here is why it wins. In a patient this immunocompromised, a bacterial infection can go from a single fever to septic shock in a matter of hours, faster than any workup can keep up. So you do not wait for a positive culture, you do not wait for a localizing sign, and you do not wait for morning. You assume infection, and you treat it empirically, right now. The mild virus, the side effect, the dehydration, they may even be true, but they are not the bet you make, because the cost of being wrong about neutropenic fever is measured in lives. Name it, and the clock starts. Step 4. Generate the solutions. Lay out everything that belongs in the plan. This is select all that apply. Think about what a neutropenic fever actually requires. You need to find the organism, so, cultures, and in a patient with a central line, from the line, and from a peripheral stick. You need to cover the infection before it declares itself, so, broad-spectrum antibiotics, fast. You need to protect a patient with no immune defenses from picking up anything new, so, protective precautions. And you need to hunt for the source, imaging, urine, a careful exam. Then, the traps, waiting for a culture to turn positive, or handing him acetaminophen and rechecking in the morning. Gather the right actions, leave the delays behind. Here is the plan, and the reason for each piece. Draw blood cultures, from a central line if he has one and from a peripheral vein, so you can find, and later narrow to, the exact organism. Give broad-spectrum antibiotics within 1 hour. That door to antibiotic time is the single measure most tied to survival in neutropenic fever. Place him on protective precautions with strict hand hygiene, because with no neutrophins, the next exposure could be the one that kills him. And complete the source workup. Chest imaging, a urinalysis, a head-to-toe look. Now the traps. Waiting for a positive culture wastes the hours that matter. Cultures take a day or more. And an antipyretic with a morning recheck treats the thermometer while the infection runs free. Step 5. Take action, and the order carries real weight, because there is a clock. You know the rule from before. Cultures come before the antibiotic, so you do not contaminate the sample. But you also know the antibiotic is the thing that saves him, and it has to be running inside the hour, so the cultures must be quick. Protective precautions and hand hygiene wrap around everything you do, and the full workup follows. Once the life-saving drug is in, sequence these the way you would actually move through the room, and keep that door to antibiotic clock in your mind the entire time. Here is the order. First, draw the blood cultures, peripheral and, if present, from the central line. Quickly, because nothing may delay what comes next. Second, give the broad-spectrum antibiotics, within the hour, ideally within 30 to 60 minutes of that fever. This is the step the whole case turns on. Third, institute protective precautions and strict hand hygiene, shielding him from any new exposure. And fourth, complete the source workup, the imaging, the urine, the exam, now that he is covered. Cultures, antibiotics, precautions, workup. The one number that must never slip is the time from the door to that first dose. Step 6. Evaluate. You gave the antibiotics on time. You did everything right. Now you close the loop. Because a neutropenic patient can turn on you fast even when the care was perfect. So a few hours later, you go back in and you reassess, deliberately. Is he stable? Or is something shifting? Check the vital signs against where they started. Look at how he seems now versus an hour ago. And ask the hard question. Is he beginning to slide towards sepsis, despite the antibiotics already on board? Because in this patient, the evaluation is not a formality. It is how you catch the deterioration in time. Here is the reassessment, and it is exactly why we never skip this step. The cultures were drawn correctly, and the antibiotics went in within 40 minutes, on time. But now look at him. His heart rate has climbed to 118, and his blood pressure has drifted to 96/58. Worse. He has developed rigors, shaking chills, and he no longer looks well. Worse. Do the math. The infection is declaring itself, and he is tipping into septic shock, the very thing we feared. You did the neutropenic fever bundle correctly, and it still progressed, because that is how fast this can move. So the evaluation names your next action. Escalate now, fluids, close monitoring, and onto the sepsis pathway. The exact arc we walked in the last case. 6 steps, and the 6th is what keeps him alive. Let's tie the case together. Your cues: a fever of 38.5 in a patient 10 days into chemotherapy, an absolute neutrophil count of 400, no localizing source, and a patient who looks deceptively well. Your action? Treat it as neutropenic fever, an emergency, cultures first, then broad-spectrum antibiotics within the hour, protective precautions, a source workup, and escalation the moment he starts to slide. And the outcomes you are steering toward: the antibiotics in on time, the source found and covered, the patient shielded from new exposure, and any sepsis caught the instant it declares. Recognize, analyze, prioritize, generate, act, evaluate. The fever alone was the emergency. Now, the next patient. You have just hung a new intravenous antibiotic, and within minutes something goes wrong. Hives bloom across the skin, the breathing tightens into a wheeze. The blood pressure drops to 78/40 and a high, crowing sound, stridor, rises from the throat. This is anaphylaxis, unfolding in real time, and one drug has to be given first, immediately, and it is not the antihistamine everyone reaches for. 6 decisions, and the first one cannot wait even seconds. That is case 203.